We are ready to start, sir. Okay. Professor Hatem will join. He's solving the problem with him.
Sure.
Okay.
Okay, sir.
It's a great honor for me to announce for another day in the very fruitful Egyptian-Indian online orthopedic course. Many thanks to Dr. Srinivas Kambhampati from India for his great effort to complete this course, and also for his effort in supporting the Indian session in the trauma webinar and in the upcoming HIP webinar. Thank you so much, sir, for your great help. Thank you, sir. Today we have, thank you, sir. Tonight we have two eminent speakers from India. Professor Shreyash Gajjar from India will speak about meniscal injuries of the knee, and Professor Hatem gohary from Egypt will speak about current concepts in meniscal injuries. First of all, we will start with Professor Shreyash, and Dr. Srinivas will be the moderator of this talk. Please, sir.
Thank you very much, sir. Good evening, everybody. As always, I would like to thank Professor El-ashhab, Egyptian Orthopedic Association, Indian Orthopedic Association, and OrthoTV for this wonderful course. I'm very pleased to invite Dr. Shreyash Gajjar, who is a very good friend of mine. He is a consultant orthopedic surgeon and unit head for arthroscopy, sports orthopedics, and trauma at Kokilaben Ambani Hospital Medical Research and Institute in Mumbai. He is also ex-editor of Indian Arthroscopy Society and reviewer of American Journal of Sports Medicine and Arthroscopy. And he is faculty in many national and international meetings on arthroscopy and knee and shoulder courses. He's also a member of Indian Arthroscopy Society, Shoulder and Elbow Society of India, Indian Orthopedic Association, Bombay Orthopedic Society, ISACOS, APCAS, and SICOT. Thank you very much for accepting the invite, Shreyash. Please go ahead with your presentation. He'll be talking on meniscal injuries of the knee tonight. Thank you. Shreyash, please go ahead.
Yeah, okay, I'll just try again. It was not allowing me. Yeah, okay.
Oh, okay.
Can you see my screen and hear me all right?
Yes.
Okay. So, hello everyone, and thank you, Srinivas, for the kind introduction, and thank you, Professor El-ashhab, for the invitation. It's a pleasure to participate in this joint meeting and always share ideas and make new friends. So my topic today is on meniscal injuries. I am an arthroscopy and sports medicine surgeon working in Kokilaben Ambani Hospital in Mumbai. It's a tertiary care center, and predominantly I do elective surgery work in both upper limb and lower limb. So talking about the meniscal anatomy, we know that menisci are concentric wedge-shaped fibrocartilaginous, with the medial meniscus occupying 60 to 65% of the medial tibial plateau, whereas the lateral meniscus is more broad and occupies 80 to 85% of the plateau. Predominantly, it's type 1 collagen, which is 90 to 95%. Also, there is a composition of fibrochondrocytes, proteoglycans, elastin, water content, and importantly, there is a circumferential arrangement of the collagen fibers. The blood supply to the menisci comes from the superior and inferior medial and lateral genicular arteries, and we all know that the peripheral outer third of the meniscus is more vascular because of this anatomy, whereas as we move towards the midline, the meniscus becomes avascular, which is a challenge in meniscal preservation. So this is what we classify in terms of our clinical assessment, the zones into the red zone, the red-white zone, which is a transition, and then the white-white zone. The menisci help in increasing the congruence of the joint, also help in increasing the contact surface area, provide joint stability, allow increased joint lubrication and nutrition to the articular cartilage, and also play a role in proprioception and, importantly, a shock absorber function. Talking about the problems, historically we've been excising the meniscus, but over the years we have recognized its importance because total meniscectomy reduces the joint contact area by 75%, increases the peak load contact pressure up to 200%, and partial meniscectomy minus the contact pressure equals a significant change in the joint kinematics. And also, just move back. Increased contact pressure overloads the articular cartilage and the subchondral bone, leading to biochemical changes in the composition, thereby leading to osteoarthritis. So when we look at meniscal tears in general, we have two varieties. One is the traumatic tears, which we see in our younger patient group. The mechanism is typically compression or rotational forces. The medial is more involved than the lateral meniscus because it's less mobile, as we know, and gets trapped very easily between the femur and the tibia plateau. The lateral meniscus is commonly seen in association with ACL ruptures because of the pivot shift phenomenon. When it comes to the degenerative tears, it's seen in the older group. They are spontaneous without necessarily a preceding injury. And again, these tears present with complex patterns because of the poor tissue quality. So in order to present results and also to help in research, meniscal tears are classified depending on the configuration into radial, oblique, flap or parrot beak, vertical or longitudinal tears, the bucket handle tears, and the horizontal cleavage tears. So these patients would typically present with a painful knee. Sometimes these are incidental findings, but we have to examine the patient and correlate it clinically to justify any active management. But generally, in a symptomatic patient, there would also be associated swelling, which following the injury would come in overnight, and patients would also present with locking, catching, or painful giving way. On examination, we would find effusion, joint line tenderness. Again, the range of motion may be limited because of pain. And for the posterior body tears, the pain would be provoked on deep flexion. And although the McMurray test is historically used for meniscal tear pathology, it is only 34% sensitive of a meniscal tear. Radiographs generally are normal in case of isolated meniscal tears. So the MRI is the cornerstone of diagnosis. In the modern day, we have 3 Tesla MRIs, which are becoming more and more sensitive and specific in picking up both medial and lateral meniscal tears. The MR arthrogram with gadolinium was previously kind of popular, and again that was to increase the sensitivity, but in modern day just a plain MRI, which is 1.5 or 3 Tesla, would give us the information regards the meniscal tears. Coming to treatment options, broadly speaking, the degenerate type would be more in favor of non-operative management, where we try a line of medications and some physiotherapy as tolerable. And if they don't respond and the meniscal tear is predominantly the source of the symptoms, then we would perhaps offer them surgery, but it is decided on a case-by-case basis. On the other hand, a primary operative line of treatment is advocated for traumatic tears and those who present with mechanical symptoms. And unfortunately, it's very important to recognize that in the younger population with traumatic tears, a trial of physiotherapy in modern day management is not recommended, simply because it would make a repairable tear irreparable with the progress in time. As far as surgery goes, we have recognized over the last several decades the importance of preserving the meniscus and its joint preservation function, and therefore meniscal repair is the mainstay of treatment in modern day, even in the transition and in certain situations even in the avascular zone, and I'll come to that subsequently. So meniscal repairs historically have shown better long-term clinical outcomes, and thereby resulting in reduced joint deterioration. And these are several publications in peer-reviewed journals which confirm these findings. As far as the timing of surgery goes, early arthroscopy is generally recommended for displaced lock bucket handle tears, so that we can reduce them and repair it before they become non-repairable. And also, depending on the severity of symptoms, one can plan early arthroscopy. And importantly, early surgery equals meniscal preservation. So even in pediatric ACL cases, for example, if there is a meniscal tear, we would like to deal with them early to prevent them to become irreparable and subsequent joint deterioration in that active group. Now, meniscal repair is generally beneficial for peripheral tears. There are two approaches. The open is slightly difficult, but it's carried out generally in concomitant with ligament surgeries or with periarticular fractures. On the other hand, the arthroscopic approach is the most common one, where there are three techniques depending on the location of the tear. The anterior part of the meniscus would be repaired better with an outside-in technique. The mid part with the inside-out, and the posterior part generally with the all-inside technique. So this is what I was highlighting in terms of the three zones. The red is the posterior part, the blue is the body, and the green is the anterior part. So for the red zone, we would typically perform an all-inside repair. For the blue zone, we would do an inside-out repair. And for the green zone, we would do an outside-in type of repair. And there are various devices in the market, both autoclavable or disposable, and they come in various configurations, straight and curved, with very low profile tips to allow us to repair the meniscus with least damage to the tissue. And also there are very low profile sutures available in the modern day. So in the outside-in technique, generally what happens is that through a puncture wound, we introduce either these special lassos, as they call it, on the left side, which is the orange handle ones, or the spinal needles, whichever is available for cost savings. One can do that when we just simply shuttle the sutures through it, and then we deliver the sutures pass through one needle into the joint through the other needle, and then you communicate the two stab or the puncture wounds on the outside, so that you can have a bridging suture onto the capsular side. And this is what it would look like from an outside-in type of a repair. Obviously, there are certain concerns. We have to respect the neurovascular anatomy in the area we want to perform the outside-in technique. So depending on the safety zones, one can decide whether or not this would be feasible. The inside-out technique, again, uses different types of instrumentation, both reusable and disposable. And again, they come in various curvatures to allow us to have a good reduction of the meniscal tear. At the same time, we can insert it from an inside-out technique. And generally, there are low-profile sutures, and these are photographs of a few which we have in the Indian market to help us perform this inside-out type of repair. So generally, for the inside-out technique, we can use one of these Halden instruments, insert it through the so if you have the arthroscope in one portal, through the opposite portal we insert this, and then the assistant just feeds in the suture needles, as you can see here, and it is exited onto the capsular side, and we make a stab incision to allow the exit of these needles. And then again, like the outside-in technique, we have to combine the two, delivery needle incision sites and tie the knots onto the capsule. We have to make sure that we don't tie it in the subcutaneous plane, but we have to dissect and reach as far as the capsule to ensure a good reduction and a strong construct of repair. And this is what it would look like at the end of that technique. Again, depending on the nature of the tear, there are varying suture configurations. The diagram on the or the photograph on the left highlights that just using a superior vertical suture may not be enough, because it may compress only the upper part of the zone. So you either use it in a divergent fashion, or you have an inferior vertical divergent suture in addition, so that you reduce the meniscus, as you can see on the arthroscopic image on the right side. So the meniscus does not elevate once we just pass the sutures through the superior surface. There are challenges as the tear patterns become more and more complex. But again, in our modern day attempt to preserve the meniscus, we have the tools and the technology to perform these complex repairs. So you can see the diagram on the left is showing a configuration for a longitudinal tear, which is a very commonly encountered pattern, followed by the horizontal cleavage tear. And that is generally seen in the older population, the degenerative type of tears. And then the arthroscopic image on the right showing a radial tear repair all the way to the white zone. So, we have realized that the meniscus is very important to reduce the progression of osteoarthritis. So it is certainly worthwhile making an attempt, especially in the acute scenario, to try and repair these tears, which at one point we were excising, leading to almost a near total meniscectomy and then rapid progression of osteoarthritis over time in these younger patients. And in modern day we have the armamentarium, much like this Swiss knife, where we can address all these complex patterns through just one instrument. And one of them, which I use in my practice, is called a zone navigator. Again, it has dedicated cannulas to direct it, to the anterior part of the meniscus or the body, and so on and so forth. So we have modern day technology to help us do that. And it comes in a kit as well, and it is reusable if cost is a constraint. But in the Western countries, this is available as a single time use. So, with these instruments, you can address, as I showed you, these are the arthroscopic images, just highlighting that we can reach out to different parts of the meniscus, front and back, to repair different types of tear patterns. So when it comes to the inside-out techniques, it is the gold standard. It has several advantages, that there are smaller perforations. It is a very strong repair, and it also allows greater flexibility in repairing complex tears, and also is a versatile approach. The disadvantages, to name a few, are that it needs an assistant to help us perform this technique, and also it adds to surgical time by a few minutes through this procedure. But what is important, irrespective of the meniscal repair technique we use, is to follow the surgical principles. And this article, published a few years ago in the American Journal of Bone and Joint Surgery, is very helpful. And I would encourage the audience today to please refer to this article. And it talks about three key features in meniscal repair. One is to anatomically reduce the tear. So it should be anatomically reducible. Biological preservation through augmentation. So in the acute situation, say for example, we are doing a repair with an ACL reconstruction, then you have a lot of biology in terms of bleeding to reach the tear. But if it's an isolated chronic situation, one needs to augment it, and I'll mention some slides to highlight that feature. And last but not the least, circumferential compression, because it is very important that we ensure that the meniscal tear is compressed from superior to inferior surface through various configuration techniques to ensure that we allow complete rather than partial healing of the meniscus, because partial healing can lead to subsequent re-tears. So just to talk you through the surgical steps for the inside-out technique, which is the gold standard, you have these low-profile sutures. So initially they were like a suture wire or a suture thread. Now we have tapes which are again flat, broader surface area, so more purchase, and don't cut through fragile tissue, especially if we are repairing the degenerate tears. So once you decide the point of entry with the first arthroscopic image, then you shuttle the needle through and pass the suture, and when you pierce it through the second point of entry, and then you deliver it out on the capsule, and you can see that the suture tape holding on to the tear nicely. And on the outer side, you can either make a small incision or a 1 to 2 centimeter incision to expose the capsule and tie the knots flush with the capsule. This is a very important point. And again, the same thing on the medial side, the same principle is highlighted. In the interest of time, I'm just going to kind of run through these images to just highlight the points. That first, we have selected the point of entry. We have passed the first tape. This is a bucket handle tear which has been reduced. So now I'm using the second point of entry, and my assistant is piercing the needle through the sheath, and you can see that coming through. And then we pull it out onto the capsular side to reduce the tear, and then we tie the knots on the capsular surface. And you can see the image on the right showing that the final repair construct. It's very low profile tapes, and that reduces the meniscus very nicely to its capsular attachment. And the posterior part, we have used the all inside technique, which I'll come through shortly. So, for isolated, so this is an example of an isolated bucket handle lateral meniscal tear. You can see the arthroscopic image on the left, but after reducing it, and creating a bleeding environment, we make sure that we can achieve this type of a stable repair. Again, just to take you back through that, so being isolated, what is important is that I tend to do a bone marrow stimulation. So I just puncture the marrow to allow some marrow elements to reach there. One can also do synovial trephination. There is now talk about using these clots as well, PRP. There are various BMAC. There are various options available. But a cheaper, quick option is to do a bone marrow stimulation or venting, which I routinely do for these isolated repairs. For radial tears, again, there are various configurations, but this arthroscopic video or image highlights that one can do a cross-shaped pattern. So, first you check the depth of the tear, and then using the inside-out technique, you pass the needles and the suture tape from the inner aspect of one portion of the tear to the outer aspect of the other. So you get a cross, as you can see here, and then subsequently you reverse the pattern onto the opposite edges, and this is what you get, like a cross-shaped repair. And it's a nice, stable, and easy technique to achieve, and the knots are tied on the capsular side. There is a technique described by Rob Laprade from the US of using a anterior tibial tunnel where you deliver these sutures and tie it onto the anterior medial tibial cortex with a button or an anchor. But unfortunately, it is a biomechanically a strong construct, but sometimes if it cuts through or if it over constrains the meniscus, it can be quite a detriment. So I generally tend to use these type of techniques rather than to do a dedicated tibial tunnel and fix it anteriorly, except for my root repairs. So this is what I was talking about. This is what Laprade and group from US have described, that they use these horizontal sutures to reduce the tear, and they deliver it through an anterior button, and then they tie it out there. Now, retracted radial tears can be a challenge, but again, it's worthwhile giving a shot, because in case if it doesn't heal, meniscus removal is always an option at a later stage. But in acute situations, you don't want to try. You want to try and preserve the meniscus. So you can see here. So this is what it will look like at the beginning. Then I'm trying to reduce or assess the reducibility of the tear, and I can get it to the edges. It's very important to use atraumatic instruments, because you don't want to damage the surface from where you're going to pass your sutures. And once that is achievable, this is what we are trying to achieve. It's like a hashtag type of repair where you're trying to get it as close as possible to allow it to heal. And again, if it's a isolated tear, then you need to do some sort of a biological augmentation. And talking about biological augmentation, there are various options available, like the mechanical abrasion, which is the historical gold standard, the fibrin clot application. You can see that arthroscopic image there. Again, it's a 10-15 minute fibrin clot preparation on the nursing table in OR. But it's important that when we tie the sutures, the fibrin clot is retained and it does not get washed out. So that is a challenging thing. Then some studies from the US have talked about meniscal neovascularization. We know about simple techniques like PRP and BMAC. And again, there is a lot of work going on 3D patient-specific meniscal scaffolds to try and preserve the role of the meniscus. Post-operative management is equally important when you repair these meniscus, and depending on the configuration, one needs to decide whether to restrict or to allow full weight bearing in the early phases. For my large and bucket handle tears, I tend to restrict the knee flexion to 90 degrees for the first 6 weeks, and do not encourage squats for at least 3 months post-surgery. And clinically, I don't do an imaging confirmation of the healing, but I look for clinical signs like no effusion, no joint line tenderness, a pain-free range of motion with no restriction in mobility to determine whether my meniscal repair has healed. And talking about some outcomes following meniscal repair. So the inside-out repair, as I mentioned earlier, is the gold standard. It has shown very good long-term follow-up with 72% success in this study with excellent functional scores. The nursing table, the all-inside devices have also evolved over the years. And initially there were PEEK implants, and nowadays we have the all-suture implants to do that kind of procedure. So this is one such implant where we perform the all-inside technique. This is again a very common meniscal repair technique in my practice, because most of the tears I encounter are in the middle or the posterior part of the meniscus. So one can achieve either a horizontal configuration or a vertical mattress configuration. The advantage of the horizontal is that you need lesser number of meniscal repair stitches. The disadvantage is that it may open up inferiorly, or you may not achieve the compression inferiorly, so you might need to have an added meniscal stitch inferiorly. The advantage of vertical mattress is that it achieves a superior to inferior compression with this configuration, but you may need to use multiple stitches to cover a large area. And so this is a video showing the all-inside meniscal. It's a device, so we'll just skip through that. Let me go to the clinical. I'll just see if there's a clinical video for that. Yeah, so this is a bucket handle meniscal tear in conjunction with an ACL. It is reducible, and you can see this synovial hemosiderin staining. So it's an acute scenario there. So I've checked the reducibility. I've prepared the tears for bleeding potential, and then I'm using this. So because of this, you can note here that already the cartilage is showing some fraying, because this bucket has been displacing against the femoral condyle, causing this abrasion of the cartilage. So you want to try and deal with these situations early. So this is the all-inside device. It is an all-suture meniscal repair device. So I have passed it through the posterior part, and I'm just passing the second suture. As you can see through that, there is a certain maneuver or steps one needs to do to deploy various types of devices, whichever you are comfortable and familiar to use. And then it delivers these low-profile sutures or tapes to achieve a nice compression at the end. And I will just kind of advance it a little. So I'm going to cut that flush with the suture configuration there, and you can see that from posterior to anterior, or sometimes you need to reduce the meniscus, have a reducing stitch, and then repair the rest of the meniscus depending on what the situation is. So this is what we tend to achieve at the end of that. Now, outcomes of meniscal repair are better when they are done in concomitant with ACL reconstruction, and also if the tear is close to the periphery. the healing rates are slightly lower in ACL deficient knees, so one needs to stabilize the knee to ensure that the meniscal repair will heal, and also in avascular zones. But we have biological augmentation techniques, so our results are regularly improving with time. So talking about outcomes of the meniscal repairs. So in general, the failure rates is around 19% with the all inside and 17% with the inside out. So the all inside with modern instrumentation failure rate matches similar to the gold standard, which is the inside out, with similar subjective outcomes and results. The complications following for the inside out possibly are nerve injuries. So we need to respect the safe zones. And also there is a chance of nerve injury with the all inside. However, it is relatively less. But with these all inside devices, there is a concern of local implant irritation, migration, and breakage. So we need to really learn these techniques, practice on sawbones or models or cadaveric labs, and then use it in our patients. So the next entity is the meniscal root or ramp lesions, again, which are of growing importance and attention to try and optimize our results. So we know that the meniscal roots anchor the meniscus to the tibial plateau, and generally a root tear is a radial tear within a centimeter of the meniscal insertion or the avulsion of the insertion of the meniscus from its root. And these are important because studies have shown that failure to repair or salvage this meniscal root tears would convert a high amount of loads and therefore lead to joint deterioration and accelerated cartilage damage over time, which is comparable to a total meniscectomy. So if you look at the natural history of a meniscal root tear, if untreated, you may have a normal joint space which progressively reduces with time. And what studies have shown is that in 2 years to 5 years time, there is a very high chance of conversion to some sort of an arthroplasty if these root tears are not addressed if repairable. So these would present either in the acute or the chronic scenario. They are more common in the older population because of degeneration, generally seen in middle-aged women. Traumatic generally in concomitance with the ACL or the PCL tears. Patients generally would present with pain localized to the posterior part of the knee, although not always. Some form of mechanical pain, pain in deep flexion, a popping sound during light activities, effusion, joint line tenderness may be associated findings. And the risk factors for meniscal root tears is varus alignment and high BMI. So we really need to look for these because these would compromise our repair outcomes. Again, like meniscal tears, there is a dedicated classification into type 1 to type 5. And MRI is again is an important tool to identify these tears, and your radiologist needs to have these specific imaging cuts and also look for these specific signs. One is extrusion more than 3 millimeters, the presence of a radial tear located near the posterior root, or the ghost sign, the absence because of the displacement of the meniscal root. These are the common MRI findings of root tears. Now coming to management, non-operative management, partial meniscectomy and root repair. So let's quickly look at what would be indicated for which patient group. The non-operative is generally reserved for elderly patients who are obese, have a higher grade of osteoarthritis or a varus more than 5 degrees, or if the tear is irreparable because it's of poor quality, as you can see here in these MRI and radiographic images. And that is what would look like an irreparable tear. You can appreciate that the quality of tissue is very poor because it's been long standing. Now, why do we need to repair the root? It is important because studies have shown that the non-operative management leads to worsening of arthritis with poor outcomes at 5-year follow-up. So this is a study which looked at 52 patients, 87% failures and 31% conversion to joint replacement if treated non-operatively. And they noted that non-operative treatment would result in poor clinical outcomes, progression of osteoarthritis, and the results were worse in women compared to men. Partial meniscectomy. So again, one would resort to this option for failed non-operative treatment in patients who present with persistent pain and locking. Partial tears are those where the footprint remains to be intact. However, what percentage of footprint is important to be intact for restoring meniscal function still remains unclear, but general rule is 50% or less. They would be candidates for partial meniscectomy. Anything more than 50% root involvement would benefit from a repair. So this is a level 3 study, which again showed that partial meniscectomy, unfortunately for root tears, is not a good option with a rapid conversion or to arthroplasty. And doing a partial meniscectomy operative treatment. So, they seem to suggest that either we need to repair it or we just leave it alone. So the question is, do all root tears need surgery? Now, if you look at the survivorship analysis of the commonest type of root repair which we do, which is the transtibial pullout, this is a study from Korea showing the 5 to 10 year results, where they showed a 92% survival at 8 years. However, what was important is that they only included patients who had middle to early osteoarthritis. They excluded the advanced stages. They also excluded patients who had varus more than 5 degrees of mechanical axis. So, overall, most of them were Kellgren-Lawrence grade 0 or 1, and they had an average joint space which was preserved by 4.7 millimeters. And importantly, it's not just finished by just repairing it. It is very important that we have a rigorous rehab. So this group advocated crutches or walker for non-weight for 6 weeks, and permanently advised these patients to avoid deep squatting. So these post-op instructions are very important. Our patients should follow to ensure that there is no subsequent failure of these root repairs. And importantly, they also excluded the high BMI group. So we have to be, when we decide which root tears to repair, this paper would serve as a guideline as to what would be our inclusion criteria to ensure that we have good results. So my indications in the present, they are acute traumatic tears in the presence of normal or near normal cartilage, associated ACL and multiligament injuries. In the chronic situation, they would be patients who would be young or middle age without significant osteoarthritis, typically the ones who are out of bridge 1 or 2, as you can see here in these images. So now coming to the techniques of repairs, again, there are various suture configurations, as you can see the cadaveric study on the right. And again, there are 2 techniques of fixing the sutures. One is the anterior medial tibial pullout technique, either transosseous or transportal, and other is the suture anchor. The suture anchor is technically difficult and not very popular. The tibial pullout technique, transosseous, is more popular, and that is what I routinely perform. So this is a video of a traumatic lateral meniscal root tear in association with an ACL. Again, there are dedicated guides which are low profile. I tend to create sockets rather than tunnels. So this is a retrograde reamer called the flip cutter. So it just kind of from inside out, you just make a centimeter of a socket. So you don't have to come all the way to the anterior tibial cortex. It reduces the bungee effect. So here you pass the sutures. I use the cinch configuration, which is biomechanically strong. And then we railroad these sutures through that socket created into the posterior tibial plateau. And you can see the reduction here. So one suture is passed for suture management, and then we pass the second suture. Again, there are dedicated passing devices which we can use to create a low profile type of repair. And then subsequently, we just bring it to the anterior cortex and tie it with an anchor or a button. And this is what we need to ensure at the end. Now, it's not always possible to see the meniscal root clearly, especially in the older group. So percutaneous MCL lengthening is important. So this is what it was before. You can appreciate that you can't negotiate your instruments through it. So if you do the pie crusting, then you increase the space and you cause less damage, and you can access the posterior part of the knee better. So a good indication for meniscal root repair would be something like this. Where the ends are of reasonable quality and you can approximate it. And we already saw the video on the lateral side, so I'm just going to kind of advance it. And this is what you want to achieve at the end. You railroad the sutures, and this is what it will look like. On the other hand, this would be a bad indication for doing a root repair. Someone who has advanced osteoarthritis, as you can see here. So perhaps if this is just a medial joint osteoarthritis, a high tibial osteotomy would be a better option rather than doing a root repair. Post-operatively, my patients are partial weight bearing for 6 weeks. They are kept in a brace for the first 2 weeks, followed by range of motion and no squats for 3 months. However, again, as we analyze the results of these root repairs, there's also a concern whether what is the outcome of these root repairs. So this paper just a couple of years ago showed that although the clinical scores improved with root repairs, unfortunately, there was no prevention in progression of osteoarthritis, and also unfortunately meniscal extrusion was not reduced. So whether that needs to be addressed as well, and hence the centralization procedure, which is to reduce the extruded meniscus as highlighted in this diagram, is now used in practice. But again, we don't know what are the outcomes of doing these techniques, which are more complex. And some opponents also say that you could devascularize the meniscus if you release it from the periphery to reduce it in the joint. So it remains debatable. Meniscal ramp lesion is again a common entity seen with ACLs. It is a disruption of the meniscal tibial ligaments at the posterior horn of the meniscus. It as much as 17% prevalence. So we have to look for them, especially in conjunction with ACL tears. Otherwise, the results are compromised. So it is not easily identified because it is located in the blind spot. So we need to access the posterior medial space and look for these judiciously. And biomechanically, if the ramp is left untreated, it has shown to lead to increased tibial translation and failure of our ACL graft over time. And pain, dysfunction, and altered knee kinematics are all responsible because of the ramp lesion, and therefore surgical treatment is recommended for these. So we have to look into the blind spot, and we have to treat them surgically without any second thought. So this is a arthroscopic video showing what a normal a ramp area would look like compared to this one, where you will see the ramp lesion. So, this is the ramp lesion. Sometimes it's a very small lesion and it's stable, then you may not repair it, but this is an extensive lesion right in the posterior part, so one has to repair it. And this is important. And again, there are dedicated low-profile instruments, and you make the posterior medial portal and you shuttle the suture from behind front, or you can use the all-inside devices, or you can use the knee scorpion device. So there are various ways of doing it. We need to just practice in the lab and repeat what we are comfortable with. So this is using the posterior medial portal. So you can see here that there is a lasso which goes from the capsular side into the meniscus. You start from the midline and proceed towards the outer part of the joint so that suture management becomes easy. And then I've delivered it through the posterior half of the meniscal body. And, you shuttle these sutures and then you tie the knots. As you can see here, these are low profile sutures at the back. You want to keep the knots onto the capsular side and not the meniscal side to prevent any rubbing with the posterior condyle articular cartilage. Likewise, a second suture is passed, and this is what it would look like at the end. So we've got 2 sutures to bridge this gap, and that ensures the repair of the ramp. So the studies have shown that repairing the ramp leads to good outcomes with very little failures, and it is a safe, effective method with high rate of meniscal healing. So in summary, root tears, ramp lesions are often overlooked, and we really need to address them in the acute scenario. Surgical repair has shown to improve patient outcomes and also increase the survival rate of our ACL or PCL grafts. However, what remains uncertain is that does root repair ultimately alter the progression of cartilage degeneration, which is the key question when we address this type of pathology. So what we've learned is that improved knowledge of meniscal function has led to significant evolution in our treatment over the years. we now resort to limited resections of the torn meniscal tissue to try and preserve meniscal volume and function. We thankfully have advanced surgical techniques and instruments to help us achieve that. And the goal in modern day is to preserve the meniscus. Thank you very much.
Thank you so much, Dr. Shreyash, for this very interesting and illustrative presentation. Dr. Srinivas will be the moderator of this part of the session. Please, sir.
Should I unshare my presentation so we can?
Yes, please, sir.
Okay, thank you.
Thank you, sir. You are muted, sir.
Thank you very much, Shreyash. So since both the talks are closely related, should we take the questions at the end, or should we take questions now? Is that
as you like? We can continue with the second presentation and then take the questions, because more or less both presentations are complementary to each other, sir. Okay?
Is that okay, Shreyash?
Yes, perfect.
Yes,
and I look forward to listening to Professor Hatem's talk as well.
Yes, sir. Thank you so much, sir.
You.
Our next speaker will be Professor Hatem gohary, Professor of Orthopedic Surgery, Kafr Sheikh University, and the manager of the Kafr Sheikh hospitals, university hospitals. Professor Hatem also will speak about the current concepts in meniscal
طيب حضرتك كده سامعني دكتور محمد؟ ادي شير اهوت. بيقول your screen is sharing. My thanks to all professors from India who share and cooperate in this program. Thanks to Professor Shreyash for his nice presentation. Now we will speak about the current concepts on meniscal injuries. Greeting from Kafr Sheikh University, Egypt. Meniscus is structure made of fibrocartilage which fits within the knee joint between tibia and femur. Each meniscus has two ends, two borders, and two surfaces. The medial meniscus is a C-shaped meniscus, has anterior horn attached to the tibia anterior to the intercondylar eminence, posterior horn anchored immediately in front of the attachment of the BCL to the intercondylar eminence. The peripheral border of the medial meniscus is attached to the medial capsule through the coronary ligaments to the upper border of the tibia. Most of the weight borne on the posterior horn, on the posterior portion of the meniscus. The lateral meniscus is circular shaped. The anterior and posterior horns are closer to each other and near insertion of the ACL. The anterior horn attached to the tibia in front of the intercondylar eminence. The posterior horn attached to the posterior aspect of the intercondylar eminence in front of the posterior attachment to the medial meniscus. The blood supply of the meniscus decides the healing potential for the meniscus. The outer one-third of the meniscus is vascular. It will heal if repaired. The inner one-third is not vascular and is nourished by synovial fluid. The middle third, which is the red-white zone, has query vascularity. The blood supply of the meniscus originates from the medial and the lateral genicular arteries. The vascular supply extends from the periphery walls, 10 to 30% of the medial for the medial meniscus and 10 to 25% for the lateral meniscus. Tears within 3 millimeters of the periphery are vascular, called the red zone, and tears more than 5 millimeters from the periphery are avascular and called the white zones. Tears in between are in the red-white zone. The meniscus is stratified fibrocartilage tissue with regional variation in its cellular structure. Chondrocytes constructs the extracellular matrix consisting of type 1, 2, and 3 collagen and glycosaminoglycans. Collagen provides structure and elasticity. Glycosaminoglycan provides structure and also attracts water. Chondroitin and glucosamine sulfate are involved in the formation of glycosaminoglycan. The menisci are wedge-shaped on cross-section and have different layers of fibers which run in different angles. The superficial fiber layer are randomly oriented, mimicking hyaline cartilage. This lower friction between the menisci, tibia, and femur. Underneath, 1/3 of the fibers are distributed in a radial pattern, and 2/3 are in circumferential pattern. As regards the function of the menisci, they act as joint filler, compensating for gross incongruity between the femoral and tibial articulating surfaces, so prevent capsular and synovial impingement during flexion extension movements. Joint lubrication, they help to distribute synovial fluid throughout the joint and aiding the nutrition of the articular cartilage. As regards stability, in all planes, especially the rotatory stabilizers, they are probably essential for the smooth transition from a pure hinge to a gliding or rotatory motion as the knee moves from flexion to extension. They also act as shock absorbing force. Load transmitting forces are carried by the menisci from 40% to 60% for the superimposed weight in the standing position. Meniscal tears, the menisci follow the tibial condyles during flexion and extension, but during rotation, they follow the femur and move on the tibia consequently. The medial meniscus may become entrapped and distorted. However, the lateral meniscus, because it is firmly attached to the popliteus muscle and to the ligament of Friesberg and Humphrey, and therefore less likely to be injured. An acute twisting injury from impact during sports, usually the foot stays fixed to the ground and the rest of the body rotates, getting up from squatting or crouching position. Internal rotation of the femur over the tibia with the knee inflection forces the posterior segment of the medial meniscus towards the center of the joint. The posterior horn may be trapped in this position by sudden extension of the knee. Vigorous external rotation of the femur while the knee is flexed displaces the posterior half of the lateral meniscus towards the center of the joint. Also, during sudden extension of the knee, an anteroposterior distracting force imposes a strain on the medial concave rim, which tears transversely or oblique. Which meniscus is common to be injured? The lateral meniscus, because it is firmly attached to the popliteus muscle and to the ligament of Riceberg and or of Humphrey, follows the lateral femoral condyle during rotation. In addition, when the tibia is rotated internally and the knee flexed, the popliteus muscle, by way of its arcuate ligament, draws the posterior segment of the lateral meniscus backwards, thereby preventing the meniscus from being caught between the condyle of the femur and of the tibial plateau. Diagnosis of meniscal tear. As regards symptoms, it may be asymptomatic. There may be pain at the joint line. The patient may complain of giving way with or without looking. An examination may be fusion, joint line tenderness, quadriceps worsening, and limitation of movement. Initial tests for examination, McMurray test. The principle is to trap the meniscus between the tibia and the femur. One hand on the knee joint line and the other holds the foot and ankle. Flex the knee as far as possible, do hyperflexion. External rotate for the medial meniscus and internal rotate for the lateral meniscus. The tibia, external rotate the tibia for medial meniscus and internal rotate for the lateral meniscus, and then extend the knee. Positive McMurray, there is clicking or popping felt associated with pain. Apples test, the patient is sitting prone with knee flexed 90 degrees, the leg rotated from side to side, compression force applied, and painful response signifies torn or degenerate meniscus. Easily test with the patient standing and knee flexed 20 degrees of the affected limb. The patient twists with the knee externally and internally. Positive test, there is clicking, pain, or discomfort at the joint line. Cooper classified the meniscal tears according to the circumferentially into 4 zones: the capsule, the red zone, red-white zone, and white-white zone, and 3 radial zones: the anterior horn, posterior horn, and the medial and the mid substance of the meniscus. Meniscal tears include maybe vertical longitudinal tears, transverse and radial tears, horizontal tears, complex and bucket handle tears. Lysakos classified meniscal tears with subsequent parameters: tear depth, tear pattern, tear length, and tear location as regards the rim width, radial location according to the popliteus hiatus, and the quality of the meniscal tissue. Traumatic meniscal tear is a meniscal tear that is associated with a sufficient knee injury and a sudden onset of knee pain. May be vertical, radial tear, and flap tears. Also tears of the meniscal band. It may also be traumatic tears that occur at the ligamentous connection between the posterior meniscal horn and the tibial plateau. Degenerative menisci, traumatic menisci, and degenerative menisci. Degenerative meniscal tears. Horizontal lesions are not traumatic in nature. Meniscal tears because of their degenerative nature, even in young patients. Meniscal tears may also be stable or unstable. Unstable meniscal tears, the central part of the torn meniscus can be dislocated towards the joint space to the center of the femoral condyle, thus evoking looking and sudden pain. The unstable meniscus fragment engages or is able to engage between the tibial plateau and the medial lateral ligament or into the notch, or it is displaceable to at least approximately 5 millimeters. A typical example is a longitudinal tear, which might temporarily evolve into a bucket handle tear. Flap tear may engage between the femoral condyle and the tibial plateau. Stable tear is a tear that's not displaceable with a probe. The picture of longitudinal tear that may progress to bucket handle tear, radial tear that may progress to parrot peak tear, and horizontal tear that may progress to flap tear. Radial and transverse tear usually occur at the junction of the posterior and the middle third, and may extend towards the periphery, mainly due to trauma, majority in the posterior horn of the meniscus. This tear disrupts the ability to distribute hook stress. The horizontal tears usually occur parallel to the tibial plateau. It divides the meniscus into superior and inferior segments. Tears can extend into articular surface of the meniscus, most common in the posterior aspects of the medial meniscus. Complex tears have two or more tear configuration. It is the most common of all lesions. Minimal to no healing potential, not amenable to repair. The discoid lateral meniscus is thicker meniscus, has more surface area, covers about 80% of the tibial plateau, of the lateral tibial plateau mainly, less vascularity of the peripheral meniscus than the normal meniscus, decreased number of collagen fibers with more disorganized cord. MRI, the discoid lateral meniscus, has transverse meniscal diameter more than or equal to 15 millimeters between the free margin and the periphery of the body on any coronal view. Continuity between the anterior and the posterior horns in 3 consecutive sagittal slices, 5 millimeter cut, the bow tie sign. And incidentally found discoid lateral meniscus is that the treatment of discoid meniscus, the non-operative management in the incidentally found discoid lateral meniscus with no symptoms, asymptomatic discoid meniscus or physical signs. Snapping knee with no other symptoms and no radiographic signs of accompanying articular lesion. Operative management, repair plus or minus suturization. If there is an instability with peripheral detachment exists, meniscal repair should be performed. Subtotal and total meniscectomy gives good short-term outcomes, but increase the incidence of degenerative changes on the long-term follow-up. Imaging study for meniscal tears. Anteroposterior, lateral, and intercondylar notch and tangential views, plain X-rays. Ordinary radiographs will not confirm the diagnosis of a torn meniscus, but essential to exclude osteocartilaginous loose body and osteochondritis dissecans and other pathological processes that can mimic a torn meniscus. The risk of developing osteoarthritis after lateral meniscectomy is greater than the equivalent for the medial side. This is due to the convexity of the lateral tibial plateau, mirroring the convexity of the distal femoral condyle. In the absence of a meniscus, there is great tendency to point loading. The medial tibial plateau is concave, providing some degree of congruity even without a meniscus. Furthermore, the lateral meniscus covers a greater percentage of the compartment and carries about 70% of the compartment load compared to only 50% for the medial side, adding to the risk of developing osteoarthritis. MRI for meniscal tears is the most sensitive. The menisci appear as low signal structures in all pulse sequences. They are best studied on the sagittal and coronal planes. On sagittal images, the menisci appear as dark triangles in the central portion of the joint and assume a bow tie configuration. MRI has been shown to have 98% accuracy for medial meniscal tears and 90% for lateral meniscal tears. Meniscal tear grading on MRI, grade 1 increase in signal, not extending to the articular surface, grade 2 linear increase density, not extending to the articular surface, and grade 3 signal extending to the articular surface. Arthroscopy is a gold standard for diagnosis and treatment through inspection of menisci, ligaments, and cartilage. Full extent, type, site of tear, and degenerative changes can be seen. Treatment of meniscal tears. The principle, the aim of the treatment of meniscal tear is to save the meniscus. The era of meniscal preservation was based on 3 pillars. Non-surgical treatment of asymptomatic meniscal pathologies despite a meniscal tear according to MRI. Repair of torn meniscus whenever possible. Partial meniscectomy and resection of as little as possible. Non-surgical management, meniscal repair, and as little as possible meniscal meniscectomy of partial meniscectomy. Non-operative treatment for the first line of treatment is the first line treatment for degenerative tears, especially asymptomatic without mechanical symptoms, acute episode without locking but with acute synovitis, incomplete meniscal tear, small stable peripheral tear displaced less than 3 millimeters without other injuries. Operative management, price, protection of the meniscus from further damage, rest by using crutches, ice, cold compression, compression with elastic bandage, and limb elevation. There is evidence suggesting that degenerative tears in older patients without mechanical symptoms can be effectively treated non-operatively with a structured physical therapy program as a first line. Even if these patients later require meniscectomy, they will still achieve similar functional outcomes than if they had initially been treated surgically. Operative treatment includes meniscectomy, partial, subtotal, and total. Meniscal repair with or without augmentation techniques, meniscal reconstruction, transplantation, and replacement. Objective of partial meniscectomy is to remove the torn mobile meniscal fragment, contour the peripheral rim, leaving a balanced, stable rim of meniscal tissue. No standard technique can be used for every case. Arthroscopic partial meniscectomy should be the last resort for most meniscal tears, even degenerative meniscal lesions, and should be limited as far as possible. It may be applicable in carefully selected patients. Patients with persistent mechanical symptoms from degenerative tears, symptomatic complex tear with a damaged meniscus, unrepairable traumatic tears. SACA meniscus consensus project in 2016 recommended arthroscopic partial meniscectomy should not be considered as the first line of treatment choice. Arthroscopic partial meniscectomy should only be proposed after a proper standardized imaging protocol and can be proposed after 3 months of persistent pain, mechanical symptoms, or earlier in cases with considerable mechanical symptoms. No arthroscopic partial meniscectomy should be proposed with advanced osteoarthritis on chest view. Partial meniscectomy, less articular cartilage degeneration, excision of only torn portion of the meniscus, treatment of choice in young adults who require vigorous activity. Indications, tears more than 5 millimeters from the menisco-synovial junction, and flap tears, and complex and horizontal tears. Total meniscectomy, complex tears of the posterior horn, anterior horn, and portion of the middle third of the meniscus is preserved. In total meniscectomy, the meniscus is detached from its periphery, indicated in extensive meniscal tears and degenerative tears. Complications after meniscectomy may be post-operative hemorrhagitis, chronic synovitis, synovial fistula, painful neuromas, thrombophlebitis, post-operative infection, reflex sympathetic dystrophy, retained meniscal fragment, capsular and ligamentous laxity, late changes, degenerative changes within the joint. However, these complications are not common. Meniscal repair. Meniscus surgery has become a long way from the old slogan, if it is worn, take it out, to currently accepted slogan, save the meniscus. The aim nowadays is to save the meniscus as possible as we can, which has guided evolving modern treatment methods for meniscal tears. Meniscal repair, the most amenable tears to be repaired are acute traumatic tears within the peripheral well-vascularized red zone, which are longitudinal vertical in orientation. In traumatic tears, the first choice is repair or non-removal. Extended indications for meniscal repair were recommended for the subsequent clinical entities. Horizontal cleavage tears in young athletes, root tears, ramp lesions, radial tears, and tears in the red-wide zone. There are three main techniques for meniscal repair: inside out, outside in, and all inside. Among them, the strongest repair has been accepted as the inside-out technique. In this technique, the tear is fixed by placement and fixation of the passing sutures from the intra-articular region with the use of special cannulae to save extracapsular area over the capsule with a posterolateral or posteromedial incision. Inside-out suture repair is the current gold standard, avoiding the introduction of suture, which could alter meniscal shape or damage articular cartilage. It also allows for compact structure spacing less than 3 millimeters apart, smaller puncture holes, and secure longitudinal or horizontal matrix suturing perpendicular to the tear. However, the inside-out method requires an open surgical incision and skilled assistant to protect the soft tissue when passing sutures. All-inside device can simplify the procedure and decrease operative time. Perhaps the reason that many providers prefer all-inside devices. All-inside approach has higher risks of new tear or tear propagation, chondral damage, and local irritation necessitating meniscal removal. Outside-in technique can be advantageous in specific scenarios or for most types of tear due to its cost effectiveness. Advances in meniscal repair devices have allowed for all-inside arthroscopic meniscal repair techniques to evolve with advantage of avoiding the need for accessory incisions. Initially, rigid biodegradable devices were used, the rigid biodegradable meniscal arrow. Suture-based devices consisting of an anchor component and a sliding knot were next generation to be developed. Suture-based device has superior pull-out strength than rigid devices. Drawbacks associated with suture-based devices include increased costs, retained polymer fragment, chondral injury, and significant learning curve with a high rate of anchor pull-out during insertion. Meniscal repair augmentation. Although meniscal repairs has a higher reoperation rate than meniscectomy, they result in a better long-term functional outcome and a better activity level. Moreover, meniscal repair was found to be more cost-effective than meniscectomy. Although the advantages of meniscal repair outweigh those of meniscectomy, arthroscopic partial meniscectomy is still more frequently performed. This may be due to the fact that the repair is technically more demanding, more time-consuming, need longer rehabilitation time, and is more expensive. In order to enhance healing after meniscal repair, a variety of augmentation techniques and biological products have been introduced. Needling, trephination, platelet-rich plasma, bone marrow aspirate, hyaluron collagen scaffold, fibrin clot, fibrin glue, mesenchymal stem cells, and growth factors. Except for needling and trephination, the evolving significant potential for biological augmentation and tissue engineering strategies in the enhancement of meniscal repair and reconstruction still requires a high level of evidence, comparative studies in order to be translated clinically to be put forward as the optimal method of treatment. Due to the relatively vascular and cellular nature of the meniscus, the first step of repair augmentation involves the recruitment of cells with healing potential. In addition to the commonly used bone marrow and adipose-derived mesenchymal cells, synovial stem cells, blood vessel-derived stem cells, and even chondrocytes have been delivered locally in the meniscal tissue repair. Cells from the meniscus itself can be harnessed to promote healing. Meniscal progenitor cells have the capacity to produce robust matrix to heal meniscal tears. Increased new vascularization more than 5-fold via treatment with angiogenin, a pro-angiogenic factor in a rapid defect model. Similarly, endothelial growth factors can promote vascularization of the inner meniscus. Factor most utilized in the meniscus regeneration is transforming growth factor B3. When added to cultures of the stem cells or meniscus fibrochondrocytes, it increases both collagen and proteoglycan production and integration strength between two edges of the meniscal tear. Potential materials for tissue adhesion and integration are fibrin glue and synthetic polymers. The fibrin glue are used clinically, utilize cross-linking pathways of fibrin clots for tissue adhesion and can increase cell migration and integration of extracellular matrix components. Synthetic polymers can maintain cell viability while significantly enhancing shear adhesive strength. Meniscal repair and ACL reconstruction. Meniscal repair in conjunction with anterior cruciate ligament reconstruction have a 93% of healing rate compared to 50% in meniscal repair alone. Anterior cruciate ligament reconstruction involves tibial and femoral drilling. This delivers local growth and clotting factors which may account for the higher repair success rates. It was also noted that acute repairs within 8 weeks of injury did better than more chronic repairs. Meniscal transplantation for patients with no degenerative changes, allograft and autograft replacement, allogenic quadriceps, patellar tendon, and infrapatellar fat may be used. Meniscal scaffolds are used to fill defect in previously partially resected meniscus and to develop the meniscal tissue by allowing migration and growth of vascular channels and precursor cells into the scaffold. In clinical practice, there are two main types of meniscal scaffolds: collagen meniscal implant and polyurethane-based scaffold. The chondroprotective effect of these implants are still controversial, and the long-term higher level of evidence comparative studies are still required to clarify the clinical efficacy of these implants. Thank you.
Thank you so much, Dr. Hatem, for this very interesting presentation. I think now we are ready to receive questions to Professor Hatem and Professor Shreyash, I think. Dr. Srinivas?
Yes, sir.
Okay.
Thank you very much, sir. Thank you very much for the excellent presentations.
Thank you, Professor Srinivas, for your effort in this combined meeting. Thank you very much. Thank you, Dr. Shreyash, for your nice, very, very, very nice and illustrative presentation. Thank you very much.
Thank you, Dr. Hatem. It's nice to connect with all of you.
It's a great effort from Dr. Srinivas. Real.
Thank you very much, sir. Thank you for the opportunity. It was my pleasure.
Thank you, sir.
So I have a few questions, if I may. I'll start off with Shreyash. Just wanted to ask you about the bucket handle tear. What suture do you use normally? And the technique, vertical or horizontal mattress, which is better? And what should be the minimum interval between two sutures when you are repairing a bucket handle tear?
So generally I go for a non-absorbable suture like a fiber wire 0 or 2-0, which is low profile. My go-to option is a horizontal mattress to try and use minimal sutures for cost effectiveness, but I would not hesitate to add a vertical or an inferior suture to ensure that the meniscus is circumferentially compressed at the repair site. And generally the distance between the two sutures is about 1 centimeter apart.
And sorry.
I agree with Professor Shreyash. I use a fiber wire for the anterior horn, fixation of anterior horn and the middle substance of the meniscus.
And what would be your indications for partial meniscectomy?
If it is damaged meniscus that cannot be repairable, or if it is in the inner third of the meniscus.
And is there a role for partial meniscectomy in elite athletes?
Partial meniscectomy
in elite athletes?
Yes,
sir?
yes.
So if they want to have a partial meniscectomy done for, say, a bucket handle tear, so that they want to go back to sporting activity, what would be your advice?
Arthroscopic meniscectomy in athletes makes them return to their level of activity earlier. But on the long term, the long-term results, osteoarthritis starts earlier.
One more for Shreyash as well. For root tears, supposing you get a patient with an 80-year-old lady or gentleman with good articular cartilage, and they have a root tear, would you go ahead with a repair of the root tear?
So again, age is not a criteria, but certainly activity is. So my first line of treatment for this age group would be conservative. And if it fails that, then I would think about an intervention. But generally, the knee arthroscopy cases are maybe maximum you stretch to 70 years of age, because otherwise there is associated age-related changes. So it's very rare to get a situation where you have an 80-year-old with very good articular cartilage to offer a root repair.
Thank you. Sir, Professor El-ashhab, please.
Yes, sir. Thank you, sir. I have a few questions to both of our eminent speakers. First question, what's the to Dr. Shreyash, what's the sensitivity and specificity of using ultrasound in the diagnosis of meniscal tears?
It's very poor. Perhaps to diagnose extrusion, one can use an ultrasound. But as you move, towards the midline, the sensitivity and the specificity of ultrasound is very poor unless in the expert hand. So even if you read literature, they say that meniscal tears are better identified with MRI.
Yes, sir. My next question to Professor Hatem, in degenerative meniscus grade 1 and 2, without any degenerative tears, and it's symptomatizing for the patients and causing pain. Would you go for arthroscopic debridement and shaving of the meniscus, or you prefer to do it conservative treatment?
We start with conservative management for at least 3 months. If the patient is still symptomatic or there is mechanical symptoms, we go to arthroscopy.
Yes, sir. And for the meniscal cysts, what about the meniscal cysts?
Yes. Also, if it is symptomatic, we do debridement of the cyst, opening the cyst by arthroscopic ways. If it is not symptomatic, also conservative.
Yes. Dr. Shreyash, if I diagnosed by accidentally a discoid lateral meniscus that's not symptomatizing for the patient, do you do arthroscopic reshaping of the meniscus prophylactic, or you leave it?
No, I only deal with symptomatic meniscal pathology.
Yes, sir. Yes.
The principle in meniscal treatment is no symptoms, no treatment.
Yeah.
No symptoms, no surgery.
Yeah. Okay. Dr. Srinivas?
We have a question from the audience as well. In ACL injury, the ACL injury is associated with lateral meniscus tear in acute injuries. and medial meniscus tear in chronic ACL injuries. So their question is, what is the management of each type of meniscal tear? I suppose it will depend on the geometry, the type of meniscal tear, isn't it?
Correct. Yeah. I mean, yes, it depends on the location and the nature of the tear. But whether it's lateral or medial, the message is to try and repair it wherever possible. Obviously, you just don't want to pass sutures and make the meniscus avascular or the joint overstuffed with sutures. But wherever reasonable, we should try and preserve the meniscus by repairing it.
And what options do we have if the meniscus is completely damaged irreparably in a young patients? Supposing it's involving a segment of the meniscus, not from anterior to posterior, but just a segment.
So again, even if it's partially repairable, one should try and attempt that. But say, for example, if it's very bad quality tissue and it's not worth repairing, then we have no choice but to do a partial meniscectomy and counsel the patient, and maybe deal with any potential issues which come up in the future.
So, Professor El-ashhab?
Yes, sir. I have a question to both of our dear speakers. Is there a rule for using PRP to augment the meniscal repair?
Still under investigation. The PRP is still under investigation in repair as an augmenting factor after meniscal repair.
Yeah, but in ACL repair, I think we can use it in many cases.
ACL, the blood and the biologics that comes from the femoral and tibial tunnels has a great role in augmenting the meniscal repair. So the meniscal repair has a higher level of success in associated with anterior cruciate ligament injury reconstruction. If the anterior cruciate ligament is left without reconstruction and the repair is done, this repair will fail soon.
Dr. Shreyash, you have any experience about using the PRP?
Yes, so for isolated meniscal tears, I used to use the PRP, but again, a cheaper option is to do the bone marrow stimulation, where you just make some punctures in the intercondylar notch and allow the marrow elements to reach the repaired site. But if I were to use PRP in conjunction with meniscal repair, it would be for an isolated chronic type of repairable tear.
Yeah. You use, I think this is more or less like the microfracture technique?
Correct. That's right.
Yes, sir.
There is microfracture, nanofracture techniques for augmentation. And the technique of repair, when it is done well by rasping of the meniscus or using the rasping or trephination of the meniscus, it will add to the vascularity and the gush of cells come to the repair site, leading to better results.
Yeah,
you're absolutely right, sir. Yes, thank you, sir.
One question.
Any other questions, Dr. Srinivas?
Yes, sir. One question to both the speakers, actually. What is your rehab protocol for different tears of the meniscus? Shreyash?
Quadriceps strength.
Yeah, Professor Hatem, please carry on. Yeah.
Sir.
Quadriceps strengthening program and non-weight bearing for at least 6 weeks. Then weight bearing after this starts as tolerated, gradually. Partial weight bearing and increase gradually, according to symptoms.
Yeah, I would agree. So generally, I tend to decide on the weight bearing status depending on the extent of the tear and also the location. Generally, for a bucket handle tear, I would keep them non-weight bearing for 6 weeks. And as I mentioned in my slide, limit flexion to 90 degrees for the first month or month and a half. For those small isolated longitudinal tear repairs, they would be partial weight bearing up to 6 weeks. But avoid deep squats for up to 3 months if the repair is in the posterior half of the meniscus.
Okay.
Okay.
I think we have no more questions. Finally, I would like to thank our dear speakers from India, our dear Professor Shreyash Gajjar, and from Egypt, my dear friend, Professor Hatem gohary. Many thanks again and again to my dear friend, Dr. Srinivas Kambhampati, for his great effort and the big effort that he did and will do for the education of the young generations from India and Egypt. Many thanks, my friend, and many thanks to also to OrthoTV for live streaming all these events live to all countries all over the world. Many thanks to Eva Pharma Company for sponsoring this event. Many thanks to you, and see you next Friday, inshallah. Thank you so much, and have a nice time. Thank you so much.
Thank you, everyone.
Thank you, sir. Thank you so much.
Bye. Thank you.
Bye.